Well, welcome everyone, and thank you for joining us today for ADAA's professional webinar, Doing Affirmative Cognitive Behavior Therapy with LGBTQ plus youth and their families. My name is Jolie Busby, and I'm the Education and Training Manager here at ADAA. A little housekeeping for today's session. This webinar is being recorded. Closed captioning and translation are available. All attendees will receive a link to the recording within 72 hours. This webinar is Q&A enabled, so we're encouraging all of our participants today to ask questions through the Q&A feature. And now I'm pleased to introduce our speakers. Dr. Ilana Seeger-Van Dyke is a senior lecturer in clinical psychology at the Wellington campus and director of the Pride Lab. Her research uses experimental and longitudinal methods to understand the social and emotional mechanisms underlying mental health disparities in populations under chronic stress, in particular LGBTQ plus people, during critical developmental transitions. As a clinical scientist, her ultimate goal is to translate these basic research findings into improved evidence-based clinical care for youth and their families. Dr. Jeff Cohen is an associate professor of medical psychology and psychiatry at Columbia University, where he contributes to education, clinical care, and research focusing particularly on mental health of LGBTQ plus youth. Dr. Cohen teaches abnormal behavior and advanced courses in clinical psychology to undergraduates in the Department of Psychology at Columbia and instructs in cognitive behavioral therapy and acceptance and commitment therapy for psychiatry residents in the Department of Psychiatry. And thank you both for being with us today. I will now turn the presentation over to you, Dr. Cohen.
Thank you so much. We're excited to be here, especially in June, which is Pride Month, and especially here at ADAA. As a fun fact, I actually met Ilana nearly a decade ago at an ADAA poster session back in Miami, because I think there was just one LGBTQ focused poster, and that was how we connected. So excited to be here with Ilana today, who I'll pass it over to in just a minute, who's done also some fabulous research into supporting LGBTQ youth. I'll just give a quick overview of what we're going to be covering, and then I'll pass it over. So we're going to talk just a little bit about terminology. We're going to talk about stress. Everyone has stress, but what is minority stress? And then how we can adapt evidence-based treatments like cognitive behavior therapy to best help LGBTQ youth, and also how to best support parents, because parents and caregivers need support too. And then we'll touch on how to be affirming, particularly as it relates to gender, and provide some resources. And of course, save time for questions. So I'm going to pass it over to Ilana to get us started.
Awesome. Thank you, Jeff. And I think I forgot to mention about my biography that I am in New Zealand at the moment. So it is 7 a.m. on a Saturday. So apologies if the coffee has not quite kicked in yet. Okay, so I'm going to take us through our first section, the two sections on terminology and minority stress. So apologies to those of you who are very familiar with this area, but it's always good to have a kind of shared understanding of the language that we're using throughout this webinar. So when we're talking about LGBTQ plus young people, we're talking about young people who have some sort of kind of non-heterosexual sexual orientation and non-cisgender gender identity. And one way that I find useful in kind of clinical practice, and then also just in life, to kind of explore these topics with folks is through using something called the gender unicorn. So this is the graphic you see ahead of you, and it kind of breaks down kind of gender identity, gender expression, and other aspects of identity into different pieces. And the goal of it is really to show that there's not kind of just, you know, a finite number of boxes or labels that people can choose to describe their identity. So for example, for gender identity, and that's being kind of how you view your own kind of gender internally, or you can see the little thought bubble with the little rainbow in it. So it's about how you feel kind of inside. And this graphic kind of shows that you can be, you know, you don't have to be all a girl or all a boy or all some other sort of gender. You can be anywhere along any of those kind of three spectrums. And so, yes, so gender identity is how you feel inside. Gender expression is how you kind of perform or express that gender on the outside using things like clothes. Sex assigned at birth is what's on your birth certificate for the most part. And then physical attraction can be who you're kind of sexually attracted to or are interested in that manner. And then emotional attraction might be who you're interested in having kind of romantic relationships or emotionally intimate relationships with. Now, in terms of kind of specific words that people use to describe their identity, a study from the Trevor Project a couple of years ago where they surveyed more than 40,000 LGBTQ young people, found that these young people use more than 100 different combinations of terms to describe their gender identity and more than 100 different terms to describe their sexual orientation. And so I always use this slide to show that, even though me and Jeff are kind of experts in this area and spend all of our time in this space, there are always words that come up that we are not familiar with. So if that's something that's making you a little nervous about this work, you are not alone. Do not worry. I personally think that this is something really exciting about working with LGBTQ young people. And I think it's really kind of beautiful and exciting that there are kind of new and wonderful terms that young people feel kind of empowered to use to describe their identity. So always be curious and just, Google the terms that you're not sure about. We also want to kind of take a quick moment to talk about pronouns. So pronouns are things you'll often see like after some of our names, you'll see she, her, or he, him. So these are the way that we refer to other people. Some people use one set of pronouns, whereas other people may use several. So some people might use she, her, and they, them, for example. Pronouns are not preferred. So maybe 5-10 years ago, folks would be talking about what are your preferred pronouns. Over time, language has kind of evolved and practice has evolved. And we now kind of view pronouns as something that are not preferred. They just are who you are, right? So it's not like you don't have a preferred name. My preferred name is not Alana, but you can call me whatever you want. No, my name is Alana, and you should call me that. Pronouns are just the same. So you should use the pronouns that people identify with. It conveys respect, helps build rapport, and there is some kind of growing research showing that using the correct name and pronouns for folks is associated with kind of reduced distress and increased engagement with services, like health services. So how do we ask about pronouns? Fairly simply. So often when I start my clinical sessions, I'll ask, what name and pronouns would you like me to use with you? And when I'm working with young people, I also ask, what about when your parents are in the room? So this is a discussion I'm having when I'm meeting with the youth alone, and just kind of giving them an option to share with you one set of name and pronouns, but maybe for a number of different reasons, they aren't comfortable with us using that yet with their family members. Perhaps their family members don't know, they're not out to their family members yet. Perhaps they know, but it's gone poorly, and so they'd prefer not to kind of cause conflict or, like make things more difficult than they already are. Follow the young person's lead. But we do know from the literature and from kind of clinical experience that kind of providing that space for youth to kind of be genuine with you and to have multiple choices at the same time can be really important for rapport building and kind of affirming LGBTQ young people. Now, you are going to mess up. I mess up with people's pronouns. It happens, right? And so what do? You apologize briefly, not effusively, right? We don't want to make the conversation about us and have the trans or non-binary person have to expend emotional energy to make us feel better, right? So just a brief, oh, sorry, I meant he. So correcting yourself and then move forward and plan to do better next time. So you may want to practice if you have someone with pronouns who that don't come fall naturally off the tongue for you. So practice in your report writing, practice in MDT or supervision. Just practice using the pronouns because it's really, really important. Yeah. And part of why it's important is because incorrect pronoun use and incorrect name use can be associated with increased mental distress. And that's what we're all here in the business of trying to improve. So you likely all know this, but we had to have a slide about it. So LGBTQ youth experience disproportionately high rates of mental illness compared to cisgender heterosexual peers. That spans a wide range of different types of kind of mental distress, depression, anxiety, substance use, etc. We also know that there is some literature showing that LGBTQ people kind of show up in clinical services more often than, well, proportionately more often. So this is a great opportunity for us as clinicians to kind of upskill and support LGBTQ people. Now, you may be wondering why LGBTQ people and LGBTQ youth experience these higher rates of mental distress. And the leading theory explaining that is called minority stress theory. It was originally created by Virginia Brooks and her dissertation, I think, in the 80s, but was kind of popularized by Alon Meyer with this paper in 2003. And it looks complicated, but I'll walk you through it really quickly. So essentially what minority stress theory says is that all of us experience kind of general everyday life stress. LGBT people experience those things too. But in addition to that, they experience kind of an extra layer of stress called minority stress, which is kind of like the unique stresses that LGBTQ people face on account of their LGBTQ identities. So it's not that there's something about being LGBTQ that increases these mental kind of types of mental distress. It's kind of the reactions to one's LGBTQ identity from society that results in this increased rate of mental health problems. So minority stress can be thought of as being distal or external to the person through events like discrimination, hate crimes, those things you kind of see on the news, but also family rejection, that sort of thing. And they can also be internal or proximal. So over time, if you've kind of had the steady drip, drip, drip across your entire life, hearing negative messages about LGBTQ people, then a lot of people come to internalize those messages. So they can experience internalized stigma and really start to believe them. Expectations of rejection kind of speaks to, if they've experienced rejection or seen other LGBT people experience rejection, you can kind of start to come to expect that, and that can be pretty anxiety provoking. And then the stress of concealment or being in the closet. We'll talk more about that in a bit. So it's the combination of general everyday life stress plus these additional minority stresses that confer this increased risk of mental health problems or mental distress. Happily for us as mental health providers, there are these kind of modifying mechanisms that we can kind of act on. In addition to trying to reduce minority stress for all LGBTQ people by doing things like voting and that sort of thing. We can also in the therapy room help buffer people's coping and social supports and help them understand and integrate their kind of LGBTQ identity into their broader sense of self. So when we're talking about minority stresses, I like to think of it kind of at a number of different levels. So we can think about kind of the structural level, like laws and institutional policies. We can think about it at the interpersonal level, so between people, family rejection, and then at the individual level, so things like internalized stigma. So I have just a quick example of each of those. So for structural, so there are many kind of anti-LGBTQ things happening at the moment and for a number of years. So this I just did last week, I think, and I'm sure it's already changed. These things are pretty fast. So this is from the ACLU's. They do a website. They do a tracker for all anti-LGBT bills happening in the country. So as of last week, they were tracking 515 anti-LGBTQ bills, over 100 related to healthcare and restricting gender-affirming healthcare, over 200 related to representation in schools, including sports, and 32 bills related to free expression, so things like book bans and drag shows. And so, it can be tempting to think, oh, well, those are things that adults need to worry about. But what we kind of find time and time again in our clinical work is that the young people know about these things, right? They have phones or they have access to the internet and they're aware of what's going on in kind of current affairs. And so you can imagine that knowing, even if you live in a state where none of these bills are being discussed, knowing that there are 500 bills that are across the country that are trying to restrict your rights and kind of undermine your existence as an LGBTQ young person. That's going to take a toll, right, on people's individual well-being. At the interpersonal level, so we can think of one example there as family rejection. That can look, so, often when I speak to colleagues, they're like, oh, well, it's not the 70s anymore, right? Like that was something that happened in the 70s where, gay young people would come out and their parents would kick them out. Well, we actually know this is very much an ongoing and current problem. So again, data from the Trevor Project, I think, showed that like 40% of homeless young people in the United States are LGBTQ. Here in New Zealand, just last year, I had a kind of close contact have to take in a trans young person who'd been kicked out of their home as a result of their parents learning about their trans identity. So it's kind of it can be a high risk thing to come out to parents. And family rejection can take a wide range of different kind of forms across from kind of direct interpersonal rejection like violence or kind of assault to things like resource and material restriction, like preventing gender affirming care, to exclusion from social and community support, so excluding youth from family events, from community and religious events, and sometimes even parent-initiated kind of conversion therapies, which, although not supported by any kind of reputable medical or health organization, still occurs very much so in religious spaces in the US and around the world. So at the final level, individual, I wanted to do a little kind of activity to try and understand how kind of concealment or being in the closet can really affect LGBTQ young people. And so we're going to do a little activity. So the first thing I want you all to do, and you don't need to put this in the chat, is just write down for yourself 3 roles or aspects of your life that are really important to who you are, but that others would not be able to tell from looking at you. So this might be things like being a sister or a parent, or being a cellist, or something to do with a hobby that's really important to you. It might be about your hometown or like where you're from, those sorts of things. So I'll give you maybe another 20 seconds just to write down 3 things or aspects of your life that are really important to you, but others that others couldn't tell. Okay, that's about 20 seconds. So when I do this activity in person, I'd have you meet some new people, but because we're on a webinar format and we're all wonderful mental health clinicians and are good at visualization and imagination, I want you to imagine that you're getting to know someone new. And I'm going to ask you some questions out loud that are common kind of get to know you questions. And so I want you to think about how you might answer these questions that I read out without revealing any of the 3 things that you just wrote down. Okay, so pretend that we're getting to know each other and we're actually having a conversation instead of this weird one-sided thing that we're about to do. And just imagine how you would answer the following questions. Okay, let's get started. So tell me a little about yourself. Tell me about your family. Do you have any siblings? Do you have any kids? Do you have a partner? Where are you from originally? Do you have any favorite places in your hometown? What do you like to do in your spare time? Do you have any hobbies? Like, do you play any instruments? Do you like to read? How did you get into your hobbies? What's your favorite way to unwind at the end of the workday? What things are you passionate about? What do you think of the news or social media? Who do you look up to? And what childhood memory makes you smile? I'll leave it there for now. And I would love to hear the chat, what that was like for you. Was that a challenging activity, or was it easy to think of how you might respond to those questions? Drop your thoughts in the chat. Was it kind of empowering? Wonderful. I love that. Others say it was very stressful to think about how to continue on in the conversation. Absolutely. It's a little unfair that so many of us have above average communication skills. Absolutely. Obviously, this is a bit of a contrived situation, and you all are the kind of best positioned for this. Yes, no questions were the hardest to get around. Wasn't sure what to do with a direct question without lying, feeling kind of fraudulent or like a fraud. Yep, made me feel like I was almost lying when trying to avoid sharing things. Difficult because you're finding yourself having to edit what you're going to say. Uncomfortable, having to refrain from sharing information that I'm proud to share with others. Absolutely. Yep, and kind of feeling kind of inauthentic. Absolutely. Thank you all for engaging in this activity. I know it's a little bit random, but I'm glad to kind of hear that for some of you, you were able to kind of think, you're able to kind of like reflect on how that concealment might impact you, certainly in this activity, but hopefully we can generalize that to how it might impact LGBTQ youth. We can kind of think about concealment impacting folks in a wide range of different ways, but since this is a CBT webinar, we can think about the cognitive, emotional, and the behavioral elements of that. So I heard kind of some kind of discussion about how it was challenging to do this activity because you're kind of in your head, right? Trying to think about, how do I dodge this question? This is a yes, no, how can I kind of pivot? So there's a lot of kind of cognitive load. Emotionally, right? So feeling like things were kind of stressful, for some people empowering, which is awesome. And some people finding it more difficult. And then in terms of behavioral, right? So folks described kind of feeling inauthentic and feeling like you weren't, often what people say is they feel like they weren't kind of engaging fully in a conversation because they're so busy in their head. So you can imagine how over time, if this was your kind of day-to-day, people, LGBTQ youth might come to kind of avoid coming out or sharing who they are, right? Because it's a lot of cognitive load, it's a lot of emotional work. And it's just so stressful, right? So there's a good paper by John Pachangas that kind of describes the cognitive, affective, and behavioral implications of concealment. So I encourage you to do that. I also really want to acknowledge some of the folks in the chat sharing that, you know, how this kind of might feel normal to them because they are trans and this is kind of what they do all the time. And so I really want to kind of acknowledge that and thank you for sharing. Okay. So I'm going to keep moving because we are on a timeline. And so this next section is going to be about kind of adapting CBT for LGBTQIA plus youth. And we're going to go through specific skills and how you might adapt them for use with this population, mostly to acknowledge minority stress, right? All of that wasn't just an activity for me to be interested in, but rather the kind of the key part to affirming LGBTQ folks is to acknowledge the unique stresses that they face in society and make sure that we're kind of really bringing that into our therapy formulations and the skills that we use. So for any good CBT is going to start with a good case formulation or case conceptualization, right? And so I wanted to share a brief case formulation. And throughout this, as I read it out, feel free to drop into the chat if there are any ways that you think minority stress might be relevant to this case formulation, or how might you, think about it in terms of Sam's case. So Sam, who uses they, them pronouns, is a 9-year-old non-binary child who presents to your clinic for social anxiety. They report anxiety about going to school because they worry that peers might judge them. They're nervous ordering at restaurants, giving oral presentations at school, and going to parties and social gatherings. Sam only has one friend who is also non-binary. At home, Sam's parents have had trouble adjusting to Sam's gender identity and pronouns and often dead name them. Dead naming is when you use someone's name that was on their birth certificate that they're no longer using. So parents say they don't know how Sam's gender will be received by folks at their church. Parents are eager for your help. So feel free to drop in the chat any ideas about how minority stress might be relevant to Sam's case. I'll give it 20 seconds or so, and then I will start sharing some of my thoughts. Okay, I will keep going just in the spirit of time. It looks like there's one thought about a lot of future negative expectations, proximal minority stresses related to negative events that they've experienced or even witnessed. Absolutely. So that expectations of rejection. Someone else said perceived rejection and validation of identity, not feeling safe and accepted by those who are supposed to be closest to you might make every day difficult and overwhelming, 100%. And lack of community to engage with for support and validation, lots of judgment, no sense of belonging. This is great. Thank you all for responding and sharing your thoughts. Feel free to keep doing so. I kind of found some of the similar pieces, right? So, someone's mentioned about parents, right? So there's clearly little pieces in here in terms of anxious expectations of rejection. So that certainly might have some minority stress origins. So it might be important to think about, okay, not only a social anxiety explanation for why parents, why they're worrying that peers might reject them, but is there something about being non-binary and being a non-binary person in the world that's contributing to that, that fear? In terms of the parents, as folks have mentioned, kind of an unsupportive or invalidating environment. In some ways, this is an enacted rejection, right? That's Sam is experiencing in some ways rejection from their parents based on their non-binary identity. And so in some ways, it's always important to consider whether anxiety is adaptive in certain situations, right? So that would be something to consider. Sam has support from within the community and that in terms of that one friend, which is awesome, but perhaps they're also concealing. It's unclear whether how their concealment of or how their non-binary identity is related to their lack of friends. So that would be something to explore. And then always, thinking as a child and adolescent psychologist, I'm always thinking about development as well. So as a 9-year-old non-binary child, we don't know anything about whether they're starting to experience aspects of puberty. Is there any stress related to body changes yet? School context, elementary schools are often less prepared for some of this compared to middle and high schools. So there's lots there. Some folks in the chat also talking about, the stress within the church community, socio-political environment. Absolutely. Cool. All right. Thank you for engaging with this. So I'm going to pass now to Jeff, I believe.
Sounds good. Thank you so much, everyone, for engaging, and thank you, Alana, for kicking us off so strongly. So we now just wanted to transition a bit more to the clinical space and think about how we can utilize all of the information that we've been discussing in an age-appropriate way, in a way that a youth could understand. So one of the ways that I think we both like to ask about minority stress when working with a child or adolescent is just by saying, what are some of the some things that are cool about being LGBTQ? And actually, we love to crowdsource, so we'd love to just get some answers from you. So what do you think, either based on your clinical knowledge or what you've learned thus far in this presentation, what do you think are some things that a youth might say are cool about being LGBTQ? And if you want to just enter that into the chat, I thought it could be fun and perhaps a little bit celebratory to see all the cool things come through. So what are some things that are cool about being LGBTQ from the eyes of a child or adolescent? So thank you, Julia. Community, authenticity. I remember one teen shared with me that when they look at trans adults, they seem really confident and they aspired to have that level of confidence. So a lot of themes I see around being genuine and related to us and authenticity, uniqueness, having opportunities to celebrate, and really think about what you want your path to look like. Yes, rainbows and sparkles. Thanks, Lauren. And people can compliment your style. Yeah, so it seems like authenticity is really one. So now, also just creating space for all of everyone's experience, and also, creating a window to where we could be most helpful as clinicians in terms of providing support. We also like to ask, what are some things that are stressful about being LGBTQ? So, yeah, similarly, it would be helpful to know, what have youth shared with you, or what do you imagine could be stressful for an LGBTQ youth? Because this can really help us delve deeper into the conversation of where we can provide support. So what could be stressful? So a lot of really helpful intel coming through, because I think this is stuff we can all now sort of keep in mind when we are encountering an LGBTQ youth in our clinical practice. So the world not being ready. We can experience bullying or teasing, figuring out, and we're going to talk about this in just a minute. How do you determine who could be affirming and who might not be? It's hard to make those determinations. And when someone's not affirming, particularly if they're a caregiver, losing housing, choosing a college. It's really helpful and validating, because we actually have a clinical example coming up about choosing a college as well. So, all right, I guess let's jump to the next slide. Thank you, Alana. So in thinking about how you might respond to minority stress in the clinical room, we ourselves find it helpful to begin with validation. And so validation is just to communicate that a person's experience and their response makes sense in their current context, given their life and experience. So example, that sounds really painful. You don't deserve to be treated that way. Or even in the scenario where someone tells you, I was expecting an adverse outcome, it didn't occur, we can say, well, it makes 100% you were expecting that rejection. I'm glad it didn't happen, but I get why you were expecting it given all the prior. rejections you've experienced. And importantly, validation really shows that you're seeing someone, you're hearing someone, and it can pave the way for change. Often, we really want to help people, so we want to jump right into change, but especially when working with people who've experienced so much invalidation, we want to create space to acknowledge that, to hold that pain, and then think about how we can empower them with our change-based strategies. So we have a couple more examples on the slide. Thank you for keeping us moving. All right, so let's actually dive into a clinical example. So, and this speaks to the difficulties around choosing a college. So Jordan, him, is a 17-year-old transmasculine high school senior diagnosed with GAD, and he's presenting with significant gender-related body dysphoria, meaning his body does not necessarily align with the way he would want it to look, or the way he'd like to embody himself. He's worrying about starting college in the fall, the health of his family, being outed, and finances. So he's not out to his family, and he worries that if his family found out about his gender identity, they would not pay for college. So a key worry cognition is, if I come out, my family would not pay for college. So question, what would you do? So if this was your patient, and just imagine, what would you do if they had GAD and they tell you, if I come out, my family will not pay for college? And we'll give that a little bit of time to percolate before we discuss. So you can enter into the chat again, and we really so appreciate everyone's participation. So maybe it's still percolating. I know sometimes when I write a longer response, it can take a minute. So I wonder, okay, so validate and then assist the patient. Right, exactly. We want to figure out, first validate, and then how do we check the accuracy of this thought, right? No one in the history of time has ever observed somebody else's thoughts. So how do we figure out how realistic this could be? Let's take a look on the next page, and we certainly welcome more ideas to come through. So of course, we want to remember not everything's a distortion. This could be a more accurate thought. So we want to check the facts. So how do you do that? Well, you could actually mention someone who shares the youth's identity, or recommend they share about someone who shares their identity to their parents. So if the person is non-binary, they could start talking about Sam Smith or another non-binary person. This is a way to test the waters to see how a parent might respond. We also might, just the way we would do on an exposure hierarchy, we might have different experiments, right? So we might say it differently we might say it to one parent and then to another parent, and try to figure out who's the most or least likely, to reject us, right? Now, and if a parent says, "Oh, that's so cool about Sam Smith," then it's likely that the youth has a better chance of, parents not saying we won't pay for college. However, sometimes that could be the case, and then we'd need to do problem solving, right? So if a worry fits the facts, we actually have to problem solve it. If a worry is inaccurate, we might want to change it. And of course, in any scenario, and I can't remember if this is going to flow into the behavioral vignette, but we always want to cope ahead for rejection, because relevant to the earlier remark, rejection can occur, housing could be lost, even if we're not expecting it. Okay, I'm going to popcorn it back to Alana for behavioral strategies. Or actually, I think I have one more cognitive strategy slide, sorry. Okay, so just some common thinking traps we've seen with LGBTQ youth. We can have expectations of rejection given past history. We can internalize the messages we get into the environment and from the environment and self-invalidate. So if we hear really negative things about LGBTQ people in our world, we can start to tell them to ourselves. And then we can also have contingent self-worth. So I have to be perfectly androgynous or otherwise I fail at being non-binary. So those are just some common thinking traps. Okay, now I'm going to pass it back to Alana for me.
Awesome, thank you. So as kind of Jeff has mentioned a little bit, so a lot of your standard behavioral CBT strategies can be easily adapted to use with LGBTQ teens. As you'll see throughout this, you don't have to do a magical different type of CBT with LGBT folks. It's just about making sure that it's kind of informed by minority stress and takes into account the kind of unique stresses that folks might be facing and the unique strengths and resilience that they have. So in terms of behavioral strategies, of course, we can talk about behavioral experiments like Jeff has been mentioning, exposures, and then assertiveness skills. So some of the research work that's been done on adapting CBT for LGBT folks has done a bunch of kind of focus groups with the community, and kind of assertiveness skills is something that keeps popping up as something that the community would really like help with. So if you do have an LGBTQ youth, and I feel like a lot of youth in general are not great at assertiveness, it might be something to consider kind of adding to a treatment plan, or discussing at least with the client to see if that's something that they might want help with. So the main thing to be concerned about with behavioral strategies as a clinician are issues of safety and the accuracy of the fear, exactly as we've just been talking about, right? So you really do want to kind of test the waters and assess whether parental rejection is likely to occur, or, you know, is there a risk of the child becoming homeless, or if there being violence? So we always want to set our clients up for success, right, in their behavioral techniques, but we really want to make sure they're safe as well. So I'm actually going to kind of skip through this behavioral strategies case example just in the spirit of time. And I think we've just talked about it. So essentially this case example is Emily, a 15-year-old lesbian who thinks that she could never handle her parents knowing about her sexual orientation. She's convinced that they hate all LGBTQ people, but when you ask for examples, she can't think of any. Based on your experience with the parents, you don't have any immediate safety concerns. So you could use behavioral experiments to kind of test the waters, as Jeff kind of talked about. So you could make a comment about an LGBT character on a TV show. I've had young people asked to go to an LGBT event like Pride with a friend to kind of test the waters, wearing a rainbow scrunchie, just kind of trying things out. And the Trevor Project has this wonderful coming out guide that's really aimed at LGBTQ young people. The Trevor Project, if you don't know, is this wonderful organization. It started to focus on reducing LGBTQ youth suicide. And they have a lot of wonderful resources and handbooks and guides. So I highly recommend this one to help LGBT young people kind of come out. Cool. Parenting supports. Yep.
Yes, thank you, Alana. I also love the Trevor. The Trevor Project guide is so helpful. So let's talk about parenting. And also, we just wanted to name, we're just sharing our perspectives based on our clinical experience and research. And, you know, as a white person, as a cisgender person, of course, my experience and a male person is not at all representative of the LGBT community or even other people who share my identities. So we wanted to encourage people to watch this video. I think we should share the link so people have it. And then Alana, I'll defer to you on what we should do in terms of watching it now.
Yeah, I think we can skip it. I don't know how to drop it in the chat right now without messing up the slides because I have it on like 3 screens, but we can yeah,
I'll do it. I'll share the chat the next time. I can put it in the chat the next time it goes back to you talking. We got it.
Perfect.
So we just
really good. It's really good. You go.
Yeah, we wanted to share it because it really does give perspectives of multiple people, and we think it's important to give voices to empower to hear from other perspectives. So I'm going to put it in the chat in just a moment. But yeah, let's go on to the next slide. So parenting work. I love working with parents. And I guess what you really want to know from the video is LGBTQ youth want their parents involved. The video tells us that. I believe Alana has a forthcoming paper about that, about patient wishes. And so not to say there's not other kids who want their parents involved, but I will say clinically, I do find that in general, there's often, you know, can you talk to my parents about this? Whereas sometimes with a cis-het youth, there might be less of that. And it might be more about how do we figure out just sharing the key behaviors with parents in order to preserve privacy. Now, of course, we want to be mindful of what a youth wants us to share. But when a youth does want the parents involved, why is this helpful? Well, it reduces the burden on the youth. And it really helps parents get support, right? Kids don't come with a manual. That's what I always say to parents. And you know, LGBTQ kids don't come with a manual. And even the best meaning parents likely did not imagine they'd have an LGBTQ child. So we really want to give them the support they deserve. And it helps parents acquire information. And it can be life-saving because we know that parental affirmation is a protective factor, whereas rejection can be a risk factor for adverse events. And we really want to allow parents to feel heard. Sometimes the parenting work is really an ongoing process. We have parents who are seen, for many, many sessions. I have parents who are actually sometimes seen for years. This might be about them processing the emotions they feel around things not turning out the way they expected, right? Parents may need to grieve, or that might not be their process, but just being open. Sometimes it's much shorter. Sometimes it's just a single session. So it can have to do with what resources are available in your clinic and what are the parent and youth desires. Sometimes you might want to do it as co-therapy. Sometimes a kid really wants you. By co-therapy, we mean having another provider work with the parent. So you might want to have a separate parent therapist, depending on, again, what's available in your clinic, or you might do it yourself. I find generally it's possible to do it myself, unless there's also a conflictual relationship, and maybe if there's it really depends on the presenting concerns. I find if it's more anxiety or OCD, it can be one therapist who does work with the child and parent, but which is similar to general anxiety and OCD work in our clinic. Whereas if it's DBT and there's a lot of parent-teen dynamic, we typically would have a separate parent coach. Okay, so as it says here, and I mentioned, can be as brief as one session. So what do we want to cover in these sessions? Yeah, we want to talk about what does it mean to be LGBTQ. We really want to give parents the space to ask the questions and reducing the burden on their kids to do this education. It's really easy to understand why people might confuse gender identity and sexual orientation. I usually say, if in a nutshell, for me, sexual orientation is about who I'm attracted to, whereas gender identity is about who I am. That's just a quick way. I'm sure there's other ways, and that's not exhaustive. And provide that information I shared already about parents' affirmation as a protective factor. We also want to point parents in the direction of appropriate resources. Often with trans kids, it's really hard. You might have youth who come in and want interventions that parents aren't ready for. Often my middle path, at least in the early sessions, is, can you use your child's correct name? Can you use your child's correct pronoun? And to point out how helpful that could be.
Awesome. Thanks, Jeff. And I just wanted to highlight some resources that I use in this space. So we've already talked about the Gender Unicorn, but this can be a really helpful tool to use with parents as well, to delineate the different aspects of identity, to understand their child's identity, and to understand, help the parent reflect on their own. I also like to use these handouts from the Family Acceptance Project, which is based in San Francisco. These are freely available on their website. So the one on the left kind of has, all of this is based on kind of systematic reviews and kind of understanding the impact of family behaviors on LGBTQ child health and well-being. And particularly, I like to use this behaviors that help version, because I think of it as kind of like a menu, kind of like Jeff was saying, like, okay, you can't do all of the things right now, but could you do some little things? So I kind of offer this as a menu of different things that they could do to show their child that they care and care about them and support them. So it can be little things, right? So it can be, tell your LGBTQ child that you love them. Tell your child that you're proud of them. Use your child's chosen name and pronouns. Welcome their LGBT friends to your home, right? So it doesn't have to be everything, but what are little tiny behavioral steps that the family can take to show and enact their support for their young person. These are just my little thoughts about working with parents. My kind of first goal is, particularly when parents are particularly rejecting or concerned, is to really align with parents on the aim to support their child. I can tell that you really care about your child and really want to make sure that they're doing the best that they possibly can be. Otherwise, why would you have brought them here, right? So, and I want to help with that as well. You want to hear them out fully, as Jeff was saying here, about their feelings about what's been going on, and validate what you can, validate the valid, as Jeff likes to say, while staying true to your affirming principles. So I'm never going to just kind of agree with them when they say kind of anti-LGBT things, but I want to validate what I can, right? So instead of saying, oh yeah, it's true that being trans is bad, I would say, what I'm hearing you say is that you're really worried about how this is going to kind of impact your child's, time at school, or you're really worried about your child's safety. So kind of validate what you can without kind of colluding with stigma. And we've already talked about teaming up. All right, Jeff, we're back at gender affirmation. We only have about 10 minutes left, so I'm wondering if folks have any burning questions, please do drop them in the Q&A. And maybe, Jeff, what do you think about kind of giving a quick run through gender affirmation, and then we'll answer any questions? Does that
Yes,
sound good?
absolutely. I think we can skip maybe the resources too, just do like 5
Yeah.
minutes or less, and we'll go right into questions. So sounds great. All right. So gender affirmation. So this can occur. There can be many types of concerns. I think this information appears on some subsequent slides, so let's just keep going for now. All right, so what is the gender affirmative model? So this has to do with a collaboration between youth, family, and providers. It's sort of the idea that we want doctors and parents and teens to all be collaboratively involved in these conversations. We're also not necessarily requiring therapy or psychometric testing. So we're not requiring someone to prove their identity. And there can also be times when additional supports, such as therapy, could be indicated. We're thinking about stages rather than simply ages, right? Because a developmental stage and where someone is at, and if their ability to thoughtfully consider an intervention is most important than just going based on an age. And we're often having follow-up, so it can be when we're thinking about puberty blockers and hormones, particularly as many youths and families do want this ongoing support, and we want to build resilience and alleviate gender stress. Okay, so yeah, so this is so gender affirmation can occur across multiple goals. So I mentioned in early sessions, I'm often trying to work with a family on using the correct name, the correct pronouns, if that's congruent with a teen's or a child's asks. And then I'm also working with them, the teen individually or youth individually, to figure out what they want, how they want to embody themselves authentically. And then not everyone necessarily wants medical intervention. Sometimes that's a myth. And some people may need medical interventions to alleviate dysphoria. So thinking about what options are available, if someone's experiencing great distress from getting their period, something like birth control can alleviate that. And that can be something that's maybe less intensive than a surgery. So often when we meet with teens, they're first really interested in things like hormones. And of course, it can vary for every person. I rarely have a youth who's asking about surgery, although that could happen. So then there's definitely affirming surgeries and procedures. There's also legal changes. And sometimes that's starting maybe just like you would with an exposure hierarchy. Do you want to start with changing your name in medical records and then progressing to changing it in other records? Okay. What's our role? So it's not our job to figure out if someone is really an identity. It's our goal to support one's self-determination and to help the youth explore embodiment goals and provide knowledge and connection to medical providers. So let's actually look at embodiment goals. So I really, I have a lot of positive judgments when I first encountered this term. And I first heard about it at WPATH convention. WPATH stands for World Professional Association of Transgender Health. I think it's in our resources. They have great resources online and guidelines for working with trans youth as well as adults. So I think there's kind of a myth that someone's transitioning from one gender to the other, and we don't want to fall into that, and we don't want to reinforce a binary. So a way around that is just to say, how would you describe your gender? How did you come to understand it as is now? What steps have you taken to be more comfortable? Are there other steps you'd like to take? How do you want to embody your gender? And that's why it's called embodiment goals. So you can think about your body as it is right now. What would you like to stay the same? What would you like to change? And then inquiring about other interventions, if that's something they're interested in, what would they look forward to? Thanks. So I think we probably can jump. So gender dysphoria is used for diagnostic reasons. And also there's other frameworks like gender incongruence, which some folks feel is understandably less pathologizing. And I think we can jump to questions unless there's more slides here.
It's just all resources after that. So
Yeah. Well, so
awesome.
questions.
Yes, so I can it sounds like we can share some of these resources with ADAA and they can share them with you. So we'll just do that and we'll just go to questions. Okay, so it looks like the first question is, in what ways do you ask for pronouns for children who may not know that terminology? How I would do it, I don't know how Jeff would do it, is probably for children who are that young, I would use like picture books. I would look and see if they can, what their understanding is of gender and what she means and what he means and that sort of thing. And use that as a kind of grounding to ask them, would they use she or he, or how do you feel inside? Do you feel like a boy? Do you feel like a girl? Do you, that sort of thing? What would you, yeah, Jeff's about the same thing. Okay, so maybe Jeff can answer the next question. I'll read it out. So can you say more about times when we could include a parent in the session for the young adult? I'm seeing a client whose parent would benefit from this. Seems to me it would be more of a dual role situation. Are there ways to include the parent and what would or wouldn't be okay for work with parent?
Absolutely. Yes. I love to include parents in young adult sessions, generally for a number of reasons. Often I find, not always, but the parent is the payer, and we don't want the parent to cancel treatment, whether it's managed care or private pay. The youth is often on the parent's insurance. That's not always the case. So, right. But I'm imagining that's one of the pros. So we want the parent to be bought into the treatment so they continue supporting the treatment. So the way I typically do it is just by starting with an introduction meeting and sort of managing expectations. So I say to a youth, why don't we have your parent? Would you want to have your parents come, a young adult? Your parents come. Now, this isn't about me sharing information. It's just about you sharing information. So let's just start with high level pieces. What are we working on? So we're working, would you want to tell them that you have OCD? You're working on that with exposure and response prevention. And you're also working on asking people at college to use your correct name and pronouns and figuring out what that youth wants to say. Then I tell them, I want to find out how to be most helpful to you. I don't see you at home. So if you're open to it, the next segment I usually do is I ask parents without the youth there, if the young adult there, if they're willing to leave, how can I be most helpful? And I explain this is not me giving information, it's just me receiving. Then I bring the youth and the parent back, and I just sort of summarize what I've heard. If there was anything that the parent shared that I think would be helpful for them to share with the youth, I facilitate that. Like all treatments of young people, negative expressed emotion from parents is not generally helpful. So if there's a lot of that, this can also be an in when you're meeting with the parents to refer to more ongoing parent work. But yeah, I start with one session like that generally because I think there can often be a misconception that we're going to sort of solve some interpersonal conflict in one session, which we're not going to. So I just say it's a way for your parents to get to know me and me to get to know them, and then we can figure out what supports are needed.
Awesome. Thanks, Jeff. The next question is a really good one about, does it take a toll on you as queer clinicians to work directly with families who are regularly repeating harmful, stigmatizing myths about queer people, or to witness harm being done? I would say absolutely. I mean, I think it's hard to be a queer person in the world at the moment. In terms of kind of what I do around to protecting my own well-being, my Instagram has a lot of kittens and puppies on it. I think having, trying to hold boundaries around how much time you're kind of engaging with some of this, and having good kind of peer consultation and being able to reach out to fellow queer clinicians and being like, geez, this was really hard for me. Can we have a venting session or a debrief? I think that can be helpful. Mindful of 1 minute left.
Okay, I'll do the next one. So when the caregiver's not accepting, that's generally not affirming. It's generally an indication you're going to need a lot of pairing sessions. And because, especially with a child or teen, they're generally always dependent on the parent not canceling treatment. So I'm actually going to be really grateful that the parent's there. If I see the parent even in my clinic, I'm going to reinforce that. I'm going to say, I know you care about your child. I know you love your child and you want to do what's best for your child. And I'm going to really have to slow down the process. So I'm also going to be working with the youth separately, and I'm going to be as available as I can to meet that parent on a weekly basis and just reinforce that they're there. And then I find over time that can shift. Well, thank you so much, everyone.
If you'd like to have 1 more minute to answer that last question, please do.
Sure, I'll let Alana take it.
Sure. So the last two questions around what do you do when parents are refusing to allow any medical intervention? I mean, this is like how you would address other things, right? Like the parents we work with don't allow various things. And so I think just, helping the youth cope with the kind of uncertainty and coping with that those boundaries being held. So I think doing gentle work, as Jeff said, in terms of working with the parent to become more supportive of those elements, but then also thinking about ways that the young person can embody their gender or embody their identities in ways that don't, if medical things aren't available to them, are there little social things that they could do? Could they be changing some of their gender expression to feel more authentic? Are there other little things like that we can help alleviate some of that distress?
And I have had teens who have to wait till they go to college and they're 18. And so it's how do you support until then and keep everyone engaged, doing what Alana said. All right, thank you, everyone.
Well, thank you both so much. Oh, I wanted to say some of the resources that have been shared today, I will include as many as I can in a post-event email to everyone. So if you have questions, you can always reach back out to me, and I'm happy to connect with our speakers today. And regarding that, thank you so much to Dr. Cohen and Dr. Seeger Van Dyke, for sharing your experience and expertise today. Extremely valuable to our attendees, and we are grateful for your time. So just a little bit real quick about ADAA. If you're not yet a member, we invite you to view the many membership benefits that ADAA has to offer. Members enjoy webinars like today and blog posts from professionals, member self-help books and publications, subscription access to Insights, which is the professional newsletter. So again, if you have any questions, please reach out to us. And on behalf of our presenters and ADAA, we thank you for joining us, and we hope to see you next time.
See you later.
Bye-bye.